So my topic today is heart failure and changes in kidney function, understanding and not reacting. We'll straight away go to the topic. Yeah. So it's like heart failure and kidney dysfunction and an overview. So this slide actually, these slides provided by Novartis, I think it is intended for the cardiologist for presentation, because the first question they are posing is how many HFFEF patients with renal dysfunction do you see in clinical practice? I was just wondering, we see only patients with renal dysfunction, so this question is out of our area. So this should be a question to the cardiologist actually. We'll go to the next slide. So the answer to that question is here, heart failure and kidney disease, concurrent chronic disease epidemic. We know about the pathophysiology of cardiorenal syndrome. You have a cardiorenal and a renocardiac syndrome. So when we see the cardiorenal syndrome, it is the renal involvement in primary cardiac disease. And as the slides show, 20 to 40% of heart failure patients have serum creatinine of more than 2 milligrams per deciliter. Probably it's mistake of 0.3. And 50 to 66% of heart failure patients present with values of eGFR less than 60, and regarding 20 to 30% of incidence of AK during treatment of decompensated acute heart failure. Now coming to the renocardiac syndromes, we all know that the incidence of de novo heart failure in non-CKD is around 20%, and patients on dialysis have a 44% 44% of patients on dialysis have some form of heart failure. Next slide. So the impact of coexistence of heart failure and kidney disease on clinical outcome. We know that when these two things happen together, there is increased risk of hospitalization, rehospitalization, need for ICU care, need for renal replacement therapy, and death. So worsening renal function has direct and independent consequence on heart failure symptoms and adverse clinical outcomes. So this cartoon shows the importance of worsening renal function and its impact on mortality. As you can see, the darker the color indicates the increased mortality. So as you can see that as the renal function deteriorates, the mortality increases. And one interesting thing is this pseudo worsening renal function. That is an area where it is a functional or a hemodynamically mediated worsening renal function, or AKA, that doesn't have the same mortality, or it has got a mortality benefit compared to a true worsening renal function or an AKI. So due to the high disease burden of heart failure and kidney disease and the complex interplay between the heart and the renal dysfunction, it is necessary to understand the changes in the kidney function during both chronic heart failure patients as well as the acute heart failure in a hospitalized decompensated patient. Now this is the pathophysiology in a chronic heart failure patient with progressive loss of renal function over time. Basically, it's a busy slide. You can see that when we start with the cardiac disease, you have a heart failure. It can be because of a ischemic or a non-ischemic heart failure, and as it progresses, the kidney disease also progresses in the same way. One interesting thing is that there is a common risk factor, you all know, for heart and the kidney disease, like age, race, gender, hypertension, diabetes, smoking, genetic predisposition, ischemic events, and drugs. So as the kidney, as the cardiac functions deteriorate, simultaneously the kidney functions also deteriorates. And there are some common modulating factors, including the humoral factors like the RAAS inhibition, the sympathetic nervous system activation, endothelial dysfunction, inflammation, and anemia. And there is progression of both the simultaneous progression of the cardiac failure as well as the chronic kidney disease. And when there is an acute event that is happening, acute decompensation of the heart failure leads to worsening of the renal functions. Either it can be a pseudo worsening or a severe true worsening and progressive renal failure. And sort of these two things interact and forms a vicious cycle. And if it is not appropriately managed, you will end up in end-stage renal disease and end-stage heart failure. So heart failure disrupts the normal kidney function and leads to cardiorenal syndrome, which further promotes heart failure progression. Now coming to the acute decompensated heart failure, the physiological changes, we are all aware that when you have an acute heart failure, there can be a forward failure which leads to decreased cardiac output, decreased renal perfusion, decreased blood flow, and worsening renal functions. Again, you can have a backward failure where there is a venous congestion, increased venous filling pressures, venous congestion, ascites, increased intraarterial pressure, the extrinsic compression by compartmental syndrome. Though all these again leads to worsening renal function. Now, with that is at the presentation in the hospitalization, and during the course of hospital stay, this patient is subjected to RAAS inhibition or uptitration, aggressive decongestion with intravascular volume depletion, and it is complicated by infection, sepsis, blood loss, and they are exposed to many nephrotoxins. So as an effect of these, you can have a spectrum from pseudo worsening renal failure to true WRF and progress to AKI. Now, next slide. Now, RAAS inhibition is a cornerstone of therapy in managing both chronic and hospitalized heart failure with the reduced ejection fraction patients. It's one of the major factors that can lead to renal dysfunction. So, generally, what happens is, as a knee-jerk reflex, once the renal function worsens, we are seeing that before the patient comes to us or before we get a consultation, the RAAS inhibition is blocked or withdrawn. But it is beneficial to stop RAAS is it beneficial to stop RAAS inhibition in chronic hospitalized patients with HFFEF and renal function dysfunction? We'll see let us understand the interaction between the heart failure, RAAS inhibition, and renal dysfunction, and then react how to go ahead. So RAAS inhibition is a life-saving treatment for HFrEF patients, regardless of worsening renal function. As you can see in this graph, you have a green area that is a slow progression of renal function at a rate of 1 ml per minute per year, and this red one is the 5 ml per minute per reduction in the GFR. And in between you have the patients with heart failure. The upper part of the slope shows without RAAS inhibition. The blue line shows with the RAAS inhibition. So you can see that RAAS inhibition is associated with lowering risk of heart failure admissions and mortality, despite an acute drop in the level of GFR. RAAS inhibition, we all know that it is not nephrotoxic, as they only have a functional effect on the renal function. Continuation of RAAS inhibitions leads to longer life expectancy and delay in worsening of heart failure with the reduced ejection fraction patients. So, first, it is necessary to act as far as the RAAS inhibition in heart failure is concerned. And this is a special situation where the dictum "first do no harm" may in this instance be harmful. So, because as you all know that this is the Get with the Guidelines heart failure registry, which shows that 1-year mortality reported in patients with RAAS inhibition or a newly started RAS inhibitors have a 1-year mortality of around 28 to 30%. But those who have discontinued RAS or those who have not at all been on RAS have a mortality of 1-year mortality of more than 40%. So patients who discontinued or not started on RAS inhibition had higher rates of renal dysfunction. So how do you manage RAS inhibitors based on the changes in renal functions in HFrEF patients? That we all know we are doing it daily. We should have a baseline renal function, compare with the baseline, assess the fluid status, whether the patient is intravascular fluid depleted, and if so, we have to replete the fluid deficit, interpret the BP in the context of usual values, reduce or withdraw RAS inhibition if symptomatic hypotension, repeated clinical and biochemical assessment serially, presence of moderate or severe hyperkalemia may override recommendation based on the changes in renal function, and in severe renal dysfunction, assess for the symptoms or uremia. So how do you manage it? This is a continuation slide. Changes in renal functions compared to the baseline. If it is less than 30% worsening of kidney GFR, then continue unless symptomatic hypertension. If the increase in creatinine is between 30 to 50, continue reducing the dose or temporary withdrawal of the RAS inhibition. Increase in creatinine more than 50%, temporarily stop RAS inhibition. Severe renal functions, stop RAS inhibition if symptomatic uremia, irrespective of the baseline function. So the next question they are posing is, which RAS inhibitor do you prefer in managing heart failure patients with renal dysfunction? The answer is very obvious. ACE inhibitor, ARB or ARNI. Will just go through that. Choosing the right RAS inhibition in HFrEF patients with renal dysfunction. So, use of ACE inhibitors, ARBs, increases the mortality in HFrEF patients with worsening renal functions. Although I have told earlier that patients with heart failure on RAS inhibition have a mortality benefit, patients on RAS inhibition, ARBs or ACE inhibitors with worsening renal functions have a 1.119 times increased risk of mortality with worsening renal function in HFrEF patients on RAS inhibition. That's what these studies show. There is a relative increased risk of mortality with ACE and ARBs. But when we come to the ARNI delays progression of decline in GFR versus ACE inhibitors ARBs in HFrEF patients. These are result of the systemic review and meta-analysis that shows that ARNI delayed the progression of decline in eGFR levels by 2.4 ml per minute per 1.73 meters square as compared to ACE or ARBs in HFrEF patients. So next slide shows that ARNI reduces the risk of worsening renal functions versus ACE and ARBs in HFrEF patients. This is again result of a systematic review and meta-analysis that shows that there is 11% reduction in the risk of worsening renal function with ARNI as compared to ACE inhibitors, ARBs in HFrEF patients. Again, ARNI showed a lower rate of hyperkalemia versus ACE inhibitors, ARBs in HFrEF patients. Again, that's a systemic review with meta-analysis which showed that 4% reduction in the risk of hyperkalemia with ARNI as compared to the ACE inhibitors and ARBs in HFrEF patients. So ARNI is preferred to ACE ARBs in HFrEF patients with renal dysfunction because ARNI is less likely to cause deterioration of renal functions and ARNI is safe for patients with heart failure and renal insufficiency. Now, some studies about effect of sacubitril valsartan renal function in chronic heart failure with reduced ejection fraction. So there we'll be discussing of the effect on eGFR, effect on serum creatinine, and effect on hyperkalemia. So this is showing sacubitril valsartan led to a lower rates of eGFR decline when compared to ACE inhibitors in chronic heart failure with reduced ejection fraction. eGFR decreased between screening and the end of follow-up by 10.2 mils per minute per 1.72 meter square in enalapril group compared to only 7.8 mils per minute in sacubitril valsartan group. And again, sacubitril valsartan group had a lower incidence of elevated serum creatinine with sacubitril valsartan versus ACE inhibitors in chronic heart failure with reduced ejection fraction. Significantly lower reports of serum creatinine, more than 2.5 milligrams per deciliter with sacubitril valsartan as compared to enalapril. Sacubitril valsartan showed lower incidence of hyperkalemia when it was again compared with enalapril. Serum potassium level was persistently lower with sacubitril valsartan as compared to enalapril. Now again, effect of the same drug in acute hospitalized patients. You can see that RNI versus ACE inhibitors in hospitalized HFrEF patients, 11% reduction in incidence of worsening renal functions, acute decompensated heart failure patients with RNI. And again, hyperkalemia, you can see there is 41% reduction in the risk of hyperkalemia after switching to RNI from ACE inhibitors in hospitalized patients with HFrEF. So the recent guidelines, recommendations of RAASI inhibition HFrEF patients with renal dysfunction. So European Society of Cardiology 2021 guideline recommendation, a transient decrease in renal function should not prompt the interruption with respect to initiation of RAASI inhibition, such as RNI. Both ACC 2022 and ESC 2021 guidelines recommend to initiate RAASI inhibition as first-line therapy in all HFrEF patients. As you can see, the ACC 20 RNI is recommended as the first-line therapy, and the ESC 21 again highlights RNI as a cornerstone therapy in HFrEF patients. Sacubitril valsartan dose recommendation by ESC 2021 guidelines for ensuring protection to the kidney. In patients with worsening renal function hyperkalemia, if urea, creatinine, or potassium does rise excessively, consider stopping concomitant nephrotoxic drugs and other potassium supplements and potassium retaining agents. If no signs of congestion, reduce the dose of diuretics. If the rise of creatinine or potassium persists despite adjustment of the concomitant medication, dose of RNA should be halved and blood chemistry rechecked in 1 to 2 weeks. If there is still unsatisfactory response, specialist advice to be sought. If potassium is more than 5.5 or the eGFR lowers to less than 30, RNA should be stopped and specialist advice sought. Blood chemistry should be monitored frequently and serially until potassium and creatinine has plateaued. These are actually the guidelines for cardiologists regarding the RNA. Now again, initiation and optimization of sacubitril valsartan based on the eGFR as recommended by the ACC. ACC advises the standard dose of 200 milligrams per day for mild as well as moderate renal failure eGFR. Up to eGFR more than 30, the usual dose is recommended. And if eGFR less than 30, they have advised starting with 50 milligram and then titrate the dose to a target of 200 milligrams. HFFEF recommends to evaluate kidney function thoroughly throughout the heart failure trajectory. Renal function evaluation should be part of regular encounter. Physicians have regular encounter that physicians have with heart failure patient, as it helps to better understand the underlying cardiorenal physiology, to improve initiation, adaptation, and continuation of evidence-based therapies, to stratify patients at risk of adverse outcome, to identify the presence of systemic disease or coexistence of independent renal disease. So to summarize, initiate ARNI in HFrEF patients with renal dysfunction, as it has proven to reduce the rate of eGFR decline, to lower the incidence of elevated creatinine, lower the incidence of hyperkalemia, and reduce the incidence of worsening renal functions. So thanks for the patient hearing.